All right, to get started, let's take a look at kind of typical or normal ear anatomy. In the very biggest context, we break down the ear into the external ear, the middle ear, as well as the inner ear structures. So everything for the external ear includes what we call the pinna or the auricle, which is what you see on the outside, the opening for the ear canal itself down to the level of the eardrum. The middle ear space then includes the eardrum proper, as well as the space just deep to that or inside of it. And it's very important for hearing as well because it contains typically 3 hearing bones, what's called the malleus, incus, and stapes in medical terms, or the common lay terms are in hammer, anvil, and stirrup type structures. The purpose of these is to vibrate as sound comes into the ear, and it serves almost like an amplifier, so it improves our sensitivity. Also significant in the middle ear space is an opening connected to a tube, which is called the eustachian tube. And this goes down to the back of the nose and throat area. In terms of pragmatic function, most people understand it best when you go up in an airplane or up in the mountains and you pinch your nose shut and blow, you can pop your ears and it equalizes the pressure. That transmission of that air pressure is conducted through the eustachian tube, and that's one of the natural functions of that tube. When you have dysfunction of that eustachian tube or it fails to develop properly, those are the children who get lots of fluid built up inside their ears, which can cause a little bit of hearing loss, but also makes them very prone to ear infections. And that's when grommets or tubes are inserted in the eardrum to help compensate for a poorly functioning eustachian tube. So that's the part of the middle ear structures. If you progress on to the inner ear structures, that's where you get into the cochlea, which is the real auditory organ, the vestibular structures, which are the semicircular canals, as well as the nerves, such as the cochlear nerve and vestibular nerves, that then carry the information from the ear to the relevant parts of the brain. If we go back through at this juncture and look at what are some of the abnormalities and problems that can occur in each portion of these, specifically with reference to charge, let's start at the external ear. So the external ear can have what's called a microtia, and that's where the auricle really doesn't develop properly. And there's varying grades that happen in terms of the microtia, from very mild, where the ear mostly looks fairly typical, to a severe microtia or a grade 3 microtia, where there's really just a rudiment of an external ear. In addition, you can have what's called aural atresia. That's slightly different in that the ear canal fails to open during development. And so in those children, sometimes you'll have a fairly normal external ear, so no microtia, but you'll have a complete atresia of the ear canal, so failure to open any kind of ear canal opening. When you have an atresia, it's pretty concomitant that you would not have any kind of eardrum on the inside. But interestingly, the middle ear space and the middle ear ossicles, those 3 hearing bones, are typically developed to some degree. And when we look at children and patients who have microtia and atresia, a CT scan is fairly common to look for those structures to see how well or how poorly those are developed. As you continue to go into the middle ear structure, then the abnormalities that we see are children who have very small or misshapen eardrums that impact hearing, absence or partial formation of those 3 middle ear hearing bones, and then also problems with the eustachian tube, which make them very prone to chronic ear infection problems. If we then progress on to the inner ear proper, then things like the cochlea are often very commonly hypoplastic, which means they don't quite develop all the way. In a very typical cochlea, the organ looks almost like a snail shell type organ and coils about 2.5 times. In our children who have charge syndrome, for example, the cochlea doesn't complete those 2.5 turns and often is just 1.5 turns as a fairly common finding on CT scan. The other abnormalities that we can see in the inner ear include things like absence of the cochlear nerve. So obviously, if you have a deficit or a missing nerve that doesn't connect your cochlea to your brain, then those children would have a profound hearing loss. Similarly, there's a very unique deficit that's seen in some of our patients with Charge syndrome, in which the nerve is present and the cochlea is present, but there's a failure of a little canal to develop that connects the nerve to the cochlea itself. We call that a cochlear aperture, and if that aperture is too small or if it's completely missing, then it's almost as if there's a bony barrier that prevents the nerve from connecting to the cochlea. And again, those children would present with profound hearing loss. The challenge in some of those children is it's hard to see on imaging definitively whether or not that's open or whether the nerve is proper or really deficient. And then this has implications for whether a child might benefit from hearing aids or a cochlear implant. If we continue on in the inner ear structures and describing those, one of the really common and perhaps the most common abnormality that we see in children with Charge syndrome is a failure to develop those semicircular canals. And this is part of your vestibular apparatus or your balance structures. Typically, there are 3 semicircular canals. Each of them is oriented in approximately a 90-degree plane to each other, so that whichever way you move your head, one of those semicircular canals is stimulated, and it tells your brain what position you're in. In a fascinating way, the children with Charge, about 89 to 90% of our patients are missing one or more of those semicircular canals when we look at them with a CT scan. You would think that that would dramatically impact their stability, their balance, their coordination, and certainly it does cause delays. It's fairly universal that we'll see some delay in motor skills, some delay in upright posture, as well as delays in walking. But it's more the rule than it is the exception that almost all of our patients with Charge who lack these semicircular canals somehow still develop a means of being able to walk and ambulate. So it reveals to us that there's just some compensatory mechanisms that thankfully are available either at your brainstem, your cerebellum, or even your brain that allow you to compensate for the lack of these specific balance structures. Stepping back just a little bit, if we consider the overall ear structures from external ear to middle ear to inner ear, it's fairly common for our patients with Charge syndrome to have some anomaly that affects every one of those components altogether. And in the context of hearing, speech, and communication skill development, obviously if you have limitations or handicaps in terms of your hearing and access to sound and speech, it becomes very difficult for those children to learn those proper speech and language skills as they go along. So the impetus is to identify any of those potential hearing problems early, as well as provide any supportive or interventions that you can in a safe manner as early as possible. As one example of what we look at clinically, here's a 4-section image that includes some MRI and CT scan from a typical patient with Charge syndrome that looks at the inner ear structures. In the top left panel, you'll see a small white area with what almost looks like a smiley type face in the center of it. That's a fairly normal looking MRI scan of what we call the internal auditory canal. That internal auditory canal transmits the hearing nerve, a facial nerve, and 2 vestibular nerves. And when those 4 nerves are properly developed and present inside that internal auditory canal, then you'll see this type of image in that top left panel. In contrast, our kids with Charge syndrome are typically deficient in facial nerves. So the nerve is commonly there, but it's very small. And the correlation that goes with that is that the children often have some facial asymmetry. one side of the face doesn't move quite as well or equal to the other side. The other deficiency that we see in some of our children with CHARD syndrome is where the vestibular nerves aren't fully present. And that goes along with their absence of the semicircular canals, which also are part of the balance system. And then finally, the cochlear nerve is the one that transmits the hearing and auditory information to the brain. And that is seen in varying degrees of poor development in CHARD syndrome. So some children actually lack the nerve completely, and then others have a diminutive nerve or it's smaller than typical. You can see a little bit of that, and I'll contrast it with the bottom panel on the right side, where there's a channel that transmits the nerve, and it's a grayish channel that hopefully we'll be able to highlight for you, that goes from the brain down this internal auditory canal to the cochlea. And you can see a very narrow little gray stripe that comes from that channel and connects out to the cochlea. The significance of these types of things are, if a patient has a cochlear nerve, for example, that means that either a hearing aid worn at the ear or a cochlear implant, if necessary, actually has a nerve pathway to transmit the sound to the brain. Obviously, if that nerve is missing completely, then putting in a hearing aid or a cochlear implant on that ear really has no impact at all. The top two pictures where you actually see images of children's ear represent some of the variation that we see in microtia, or malformation of the external ear. On the top left panel, that's more of a milder microtia, in which the ear is recognizable as an ear, but it's missing some of the folds and some of the definition that make it look more than a typical ear would appear. And then just adjacent to that on the top right is a slightly more underdeveloped ear. A lot of the folds, which we call the antihelical folds, for example, are missing. The ear looks a lot smoother with a lot less of the ridges and definition that would be typical. And Meg Hefner, who's one of the longtime geneticists and earliest participants in the CHARD syndrome effort, has almost gotten to the point where she can look at a child's ear alone and tell you that this child probably has CHARD syndrome. So it's one of the most consistent and fairly prototypical features that we see clinically in children with CHARD. Just below those two pictures of the external ear are some CT scans, and they show you some of the typical findings in a child who might have an atresia of the ear canal or failure of the ear canal to open up. The bone appears as white on CT scans, gray as soft tissue, and air shows up as black. If you look closely at those bottom two panels, you should see an opening from the outside world as it goes into the inside of the ear. That would be the ear canal typically on CT scans. But you'll see that there's a solid wall of bone, albeit thin on a couple of these, that demonstrates an atresia. So in most of our atresia patients, we'll see a failure of the bone to open up where the ear canal should be. One of the really common questions that we get from families and patients is how hearing is measured, what are the tests that should be done, and then what are the implications of some of those test results. So the basic and most fundamental hearing test or audiologic test that we do for our patients is the audiogram. And on this image, if you look at the chart portion of this, you'll see numbers that go across the top, ranging from 250 over to 8,000 and 12,000. Those represent the frequencies, or in common terms, the pitch. So 250 and 500, for example, would be very low pitch sounds, and 8,000 would be the highest that we typically test. Going above that, people definitely have the ability to hear sounds as high as 12,000 hertz, but in day-to-day life, it doesn't seem to have as much relevance. So across the top is the frequency or pitch of the tone that we're trying to test for sensitivity. Going down the vertical axis along the left side of that chart, you'll see numbers that range from -10 down to 120 decibels. So this is the hearing level, or the volume in common terms, of what you hear. If you looked on this particular audiogram example, the red circles and connected lines represent the right ear, and the blue lines and boxes represent the left ear. In fairly normal, standardized hearing tests, most people can hear sounds in that frequency spectrum between 250 to 8,000 hertz at softer levels than 20 decibels. So if you look on the left side of the chart where it says 20 decibels, most people can hear those tones above that line. So the lower the number, the more sensitive you're hearing. In contrast, as you go further down the chart, the decibel level, or the loudness, gets greater, and that means you must have some hearing loss because you can't hear those tones until we turn the volume up significantly louder. If I were to look at and analyze this sample audiogram, the right ear in red is perfectly normal and has a fairly flat, normal hearing test. This person can hear sounds as soft as 5 decibels and even 0 decibels. One of the idiosyncrasies is that 0 decibels does not indicate no sound at all. The standard for 0 was actually set at a World's Fair back in the 1970s, where they pulled in tens of thousands of people and they tested them in a hearing booth to see what was the typical sound level where 50% of the people could just barely hear a sound, and then they labeled that as 0 decibels. So it's a very relative scale. Some people get confused when they see that their child responded at 0 decibels and they said, how can they hear no sound at all? But that's really not what they're talking about. And some people actually can test at minus 10 decibels, which is super sensitive hearing. But to get back on track, circle back to this specific example. So this patient has a normal hearing right ear, whereas in the left ear, their low pitch hearing starts out at normal. And then as you can see, the blue curve drops down fairly significantly till at the highest pitches, it's almost down in the severe to profound hearing loss range. This raises one of the questions that we frequently get asked, which is, what percent hearing loss does my child have? Or what percent hearing loss do I have? This is fairly typical in that a lot of our patients will show a sloping hearing loss as opposed to a flat hearing loss pattern. So at the low frequencies, I could tell this patient very accurately that they have 0% hearing loss. But in the highest pitches, I would have to tell them that you have something like a 90% hearing loss. It doesn't really average out well to give them a summed average of that type of hearing range. But the audiologist will typically describe this as a mild sloping down to severe to profound hearing loss in the left ear with a normal hearing right ear. This is pure tone audiometry, is the name given for this type of testing. And this can typically be done in a booth. And some of our children, at least when they're 18 months of age to 24 months of age, if they're typically developing, are able to complete these type of ear-specific and tone-specific hearing tests. This gives us a really good overall assessment of how the ears function. But in day-to-day life, one of the more helpful things is something called speech audiometry. So as opposed to that pure tone audiometry test that gives you that chart, instead the audiologist will present words and then ask the patients or the subject, when can you hear these words? Speech and words is made up of a much more complex mix of all those frequency spectrums. And in day-to-day life, speech audiometry actually parallels how the person is performing in the real world. So most people can hear speech and words somewhere around 15 decibels or softer. And then once you cross 20 decibels, then there's definitely some impairment that we see in day-to-day life. Included in that speech audiometry section is also something called speech recognition. In speech recognition, we'll acknowledge if a patient has a hearing loss. let's say as a rough example, we know that somebody can't hear words softer than 40 decibels. To test their speech recognition, we'll actually turn the volume up to 50 or 60 decibels so that we know for certain that it wasn't merely a volume issue. The patient was able to hear it. And then in this speech recognition test, we'll present 20 or 30 words, things like hot dog, baseball, phonetically balanced, two-syllable words, and then we'll ask the patient to report back what they heard. Most patients can score 90% or greater on that type of speech recognition test. The relevance of that test is very important with regards to hearing aids and cochlear implants. So for example, if you have even a severe hearing loss, but your speech recognition score is still 90%, that means if we just provide that patient with volume, for example, a hearing aid, then they'll be able to understand speech clearly. Same patient with severe hearing loss, but let's say their word recognition score is very poor at 40%. If you try to fit that person with a hearing aid, they'll tell you, I can hear that you're talking much easier, but the words are all garbled. And so I can't understand what you're saying. And those patients are very poor hearing aid users, whereas the first patient with a good speech recognition score is actually an excellent hearing aid user.